Hey everyone. So in this video, I'm going to talk all about heart attacks and what the actual causes of heart attacks are, and how medicine has gotten it kind of wrong about this, which shows because despite their best efforts, heart attacks still happen so commonly. Now I tried to think of so many ways I could make this video more entertaining for you guys. But the more and more I thought about it, the more I felt like I would do it a disservice if I didn't show you everything that there is to show you and give you a complete understanding of this. And so I had to do it in more of a lecture format with PowerPoint slides, that kind of thing. So some of you may find that boring. It is a little long, but if I'm really going to do this justice and give you guys the information that you deserve about heart attacks, I had to do it this way. So let's get started. I'm going to share my screen. Okay, so today we're going to demystify heart attacks. They're kind of this mystery in medicine, right? People keep having them, and medicine keeps telling you all these things to prevent them, but it's not working. And so we're going to get to the bottom of what causes heart attacks today, the real actual cause. So just to start, just a little bit about my story for those of you who aren't aware of why I'm so interested in this topic. Um, I'm a chiropractor by trade, although I don't practice chiropractic anymore. I just do online health consulting for people with heart disease. But I've always been very health conscious. So ever since I learned in college that I could live my life a certain way and have a very direct impact on my health, and I thought it was curious that no doctors ever really told me that before, that I could change my lifestyle and have an impact and literally reverse inflammatory diseases I had as a kid, like asthma and allergies, and used to break out in chronic hives all over my body. So I got really motivated into health in college. I've always been very health conscious. I always ate a whole foods diet of various types. I was even on a plant-based diet at one point, paleo diets, keto diets, carnivore. I've tried lots of different whole foods diets, but I've always eaten a whole foods diet. I've always exercised regularly. I've always played sports, been very athletic and love to be moving my body around with playing sports and stuff. I've always, to my best of my ability, avoided toxin exposure. And I'm also type 1 diabetic. I was diagnosed as a type 1 at age 9, and my A1Cs are consistently within the good range for a type 1 diabetic. Not completely normal, but pretty close to someone who would be a non-diabetic. So I've always done that ever since after college. I'd say in high school and college, I didn't manage my blood sugars very well, but in my entire adult life, I've been managing them well. And then in June of 2020, a nurse practitioner I was seeing for type 1 recommended I do a calcium score of my heart to see how much calcified plaque there was in the arteries of my heart. And I came back with a perfect score of 0, which she was surprised to see. And I was very happy about. And technically, the research is very clear that people with a 0 calcium score are at very low risk for a cardiac event, for a myocardial infarction heart attack. You can see here the study shows that people with a 0 score, very low, 1.1 to 1.7% risk. So there's still risk, but it's very, very low. So here, I feel like I'm doing pretty good. However, despite that, 6 months later, I had a widowmaker heart attack out of the blue. And we'll get more into why that is, and you'll discover, I think, why that happened in me by the end of this presentation. So you can see the blockage here formed. You can see a lack of blood flow here, and we're going to really talk about this image here today and try and understand what's going on here to understand what really causes heart attacks. Now, before we move on, I just want to say that I never had a COVID injection. People see that timeline of January 2021 and they say, oh, these things were causing clotting and that kind of stuff. But I never received a COVID injection during this time. So we can't say that it was that. But not only that is that there was no hard plaque because the CAC score I had 6 months prior had no calcified plaque, no hard plaque in there. But there was also no soft plaque. Aside from that blockage, they found very minimal plaque anywhere in the body or in the coronary arteries. So, I mean, they said they found a very mild amount of plaque in the right coronary artery, but everything else was completely clean. There was just this 100% blockage in the left anterior descending artery of my heart. So it left me in the hospital, kind of wondering what the heck happened, right? And so, I didn't get much answers from the doctors, which I've gone into on many podcasts and everything about that story. But I was asking questions. I was curious. I was like, hey guys, what did I miss? All this kind of stuff. And I kind of got broken record responses, and not really any explanations for why this could have happened. But where it left me was that there was damage to the tissue. The septum of my heart between the two ventricles had damage to it, because it lacked blood flow for a while, technically. Or that's the understanding, anyways. And so my ejection fraction of my heart on echocardiogram was declined. It was 30 to 40, 35 to 40%, which normal is 50 to 70% ejection fraction. So my heart wasn't contracting and functioning like it's supposed to as well as it should. And the tissue of my heart, you can see the mid and apical anterior septum and apex are akinetic, meaning that when the heart is sending its conduction signal down there, there's tissue at the end of the heart down there that's not conducting signal. So that electrical signal. So it was dysfunctioning. Okay. And then a few months after the heart attack, maybe 2, 3 months afterwards, I started doing cardiac rehab. And I started to notice on the treadmill that my right lower leg was very painful. And so, um, and I couldn't walk fast to an airport. I definitely couldn't play soccer. I definitely couldn't snowboard, things like that. And it took me a while before I went to get that checked out. I figured out that I could ride a bike and it wouldn't hurt. So I would ride my bike or get on an exercise bike and things. But it took me a while. So 6 months after the heart attack, I finally got in to see a vascular surgeon, and they did this ultrasound test, and they found a 70 to 99% blockage of plaque in the femoral artery in my right leg, and that was restricting the blood flow to my lower leg. So whenever I would exert myself, I wasn't getting enough blood flow to that leg, and it was very painful, and that's why those symptoms were happening. I later found evidence that the heart cath procedure they did to place the stent when I had the heart attack, there is some evidence that that can cause changes in blood flow dynamics down my leg, depending on how it heals up and everything. And that change in blood flow dynamics down my leg is what caused this plaque. Because otherwise, there's no explanation for it. The morning I had the heart attack, I did a HIIT workout with no pain in my leg, absolutely nothing. And now all of a sudden, I can't even walk without pain in my leg. And it's the same side leg where they did the intervention. It kind of makes sense that that was the cause. So that's where I was left with these issues here. Now, like I said, in the hospital, I didn't get many explanations as to why I had this heart attack. I just gets kind of a broken record type of thing. Your cholesterol is high. That's what I kept getting. And I knew that it was high. I knew that my cholesterol was high at that time. And you can see here that the cholesterol 442, LDL 372. This was a few months before that CAC score. So yeah, my cholesterol was high, but I knew that, and I knew this because of the way that I was eating, which I'll talk about in a minute. But this high um, cholesterol levels was always in the context of low inflammation, right? So low hsCRP, low homocysteine, and those types of things. So the inflammation in my body was very low, but the cholesterol was high. And so why was it high? So there's a lot of new evidence coming out, mainly from Dave Feldman and his group of researchers that he works with, Adrian Sotomoto, Nick Norwitz, lots of different people out there, showing that what our cholesterol is really based off of our metabolism. So if your body is burning more carbohydrates for fuel, then your body doesn't need to deliver as many fats to the tissues, and fats are delivered via LDL molecules. So if you're eating carbohydrates, it can keep the LDL molecules somewhat low because it doesn't need to deliver those fats. However, if you restrict carbohydrates, and your body has one fuel source to burn, and that's delivering fatty acids and making ketones, then the body has to deliver more of those fatty acids to the tissues because you're not giving any other fuel source, and it does that via LDL, and LDL can go up. And this seems to happen in people who are leaner, more athletic, like me. And this is exactly what I was seeing. I was on a very low carb diet because I find that the easiest to manage my type 1 diabetes. And that resulted in these elevated levels of LDL in me, always in the context of low inflammation and good metabolic health. And so Here, there's some papers written about this, the lipid energy model. You can go read about that. And then just a few different papers by these authors. Increased LDL cholesterol on a low carbohydrate diet in adults with normal but not high body weight, a meta-analysis. Elevated LDL cholesterol with a carbohydrate restricted diet, evidence for a lean mass hyperresponder. It's kind of what Dave Feldman has labeled these people. And so low carb diets can do this in some people. And the conclusions of these studies are that the data suggests that in contrast to the typical pattern of dyslipidemia, which is elevated cholesterol, greater LDL cholesterol elevation in on a carbohydrate restricted diet tends to occur in the context of otherwise low cardiometabolic risk, which is what I was seeing, this elevated LDL with low inflammation, good metabolic health numbers, also predicting low LDL risk. So I just want to point that out there, that this is kind of a something that medicine can't really explain. We're getting this thing they're saying increases the risk of heart attacks, although we're going to see that it doesn't here in a minute, this LDL, but we're also seeing good changes, low inflammation, good metabolic health, which are things that decrease the risk of heart attacks. So how could it be the same thing? How could the same things be happening at the same time like that? That doesn't make sense, right? And there's this one person experiment done by Nick Norwitz, this Oreo cookie treatment, which is very interesting and illustrates this point very well. So basically, what Nick did is he's the person that goes on this low carb diet and his LDL goes up, and so he what he did was he went on that diet. His LDL went up. You can see on day 0 that it was at 384, and then he decided to eat 12 Oreo cookies a day for 16 days, right? And when he ate those carbohydrates, he was giving his body carbohydrates and his LDL plummeted and went down to 111. Okay. So then he went back on his low carb diet and his LDL went back up. And you can see by the time he started the second leg of this experiment, his LDL was at 421. And then he took a statin drug, a pretty good dose of rosuvastatin, 20 milligrams. And it dropped his LDL as we would expect. That's what statins do with cholesterol lowering medications. But it only dropped it to at its lowest point, 284. And that was over 6 weeks, right? So much longer than 16 days. So the Oreos worked twice as good, more than twice as good as the statin, and they worked so much faster if lowering LDL is what you're looking for. So this just illustrates that what your lipids are is about metabolism. It's really about nothing else, in my opinion. So if you have more carbohydrates in your diet and you're leaner and fitter, you're probably going to see drops in LDL. If you have more fats in your diet, so restricting carbohydrates completely, and you're leaner and fitter, your LDL is going to go up because it needs a different fuel source. And that's pretty much what this means. So in the context of that high LDL that I had, I still had a heart attack. So does that mean that it was the high LDL? I mean, that's what cardiology would tell us, right? But I just want to point out that every single study here, well, first of all, every single study that medicine uses to say that high LDL cholesterol is associated with higher risk of heart attacks and heart disease in general is an associational study. It's not a causation study. So all you can say is that these two things are happening at the same time. Conversely, all these studies I'm showing for you right here are studies that show that higher cholesterol is not associated with higher rates of cardiovascular disease, but is associated with longevity. These studies show that people with higher cholesterol as they age have higher cognitive abilities. They have lower rates of infection, lower rates of heart disease, lower rates of cancer, and lower all-cause mortality in general, right? Lower mortality from anything, death from anything. This one study here summarizes it well. The idea that high cholesterol levels in the blood are the main cause of cardiovascular disease is impossible because people with low levels become just as atherosclerotic as people with high levels, and the risk of suffering from cardiovascular disease is the same or higher. And that's from a study that looked at all the evidence for this cholesterol theory and association with atherosclerosis and heart attacks. Now, specifically to heart attacks, there's a few studies I want to show you. This study in 2009 looked at almost 232,000 people in 541 hospitals, which ended up being almost 60% of all the heart attack admissions from 2000 to 2006. So people were admitted to the hospital and having a heart attack, and within 24 hours, they took their cholesterol levels. And what they found is that 75% of the subjects had normal LDL levels under 130, and 50% had optimal levels. So 75% of people had what medicine considers normal LDL levels, that they still had a heart attack, right? So that's not really adding up. in this idea that the high LDL causes plaque and leads to heart attacks. Now, this study here took 21 different clinical trials of statin drugs and basically showed that, yes, statin drugs are very good at lowering LDL, although Nick showed that Oreos were better, but they're very good at lowering LDL. However, the results here say that this meta-analysis suggests that the absolute risk reductions of treatment with statins in terms of all-cause mortality, myocardial infarction, heart attack, and stroke are modest compared with relative risk reductions, and the presence of significantly heterogeneity reduces the certainty of the evidence. A conclusive association between absolute risk reductions in LDL-C levels and individual clinical outcomes was not established. So basically what they're saying is that lots of the studies that they do these statin trials on, whether it's the Jupiter study, the Ascot trial, the West of Scotland trial, there's so many different trials out there. What they do is they report it as relative risk, and relative risk kind of inflates the results and makes them look better than they actually are. But if you look at absolute risk, like the actual risk reduction of using statins, it says that it's very negligible here, and that they could not, like, they was so small, the risk they, or the decreased risk they do see from statins was so small that they couldn't really say that it was that. There's just as much likelihood they repeat the study, and it's just a small difference the other way. And so what this shows is that lowering LDL with statins is not very good at preventing heart attacks. Now, there's a few different studies here I want to talk about. This one shows that a STEMI heart attack is one of the most severe heart attacks, ST elevation myocardial infarction. This study looked at the standard modifiable risk factors. So some of the main things they think are associated more highly with heart attacks. They call them the SMRFs. Hypercholesterolemia, high cholesterol, hypertension, high blood pressure, diabetes, and smoking. And they found that what's interesting is that in 2006, the proportion of people who had a heart attack with and also had one of those standard modifiable risk factors was 11%. Did not have one of those standard modifiable risk factors. Sorry. People who had a heart attack and did not have high cholesterol, did not have high blood pressure, did not have diabetes, and weren't smokers. 11% of the heart attacks that happened were people like that. And that increased in 2014 to 27%. So the proportion of people with heart attacks explained by having these risk factors is increasing, or explained by not having these risk factors is increasing, right? So it's showing that a growing number of people don't have high cholesterol, they don't have diabetes, and they're still having heart attacks. So how can we explain that? And I'm going to try and explain that here in this presentation. Now, this is another very interesting study that I wanted to bring up. This looked at different outcomes in people, or different characteristics of people who had a heart attack from 2011 to 2022. So this 11-year span. What they found here is that mortality for both myocardial infarction subtypes was higher in young women and was associated with more non-traditional compared to traditional risk factors, right? So basically we're saying that the non-traditional risk factors that they look at associated higher with higher rates of heart disease than the traditional risk factors, which everybody thinks is causing heart disease or causing heart attacks, right? And so the traditional risk factors they looked at were, again, high blood pressure, dyslipidemia, high cholesterol, diabetes, tobacco use, smoking again, and in this case, they included obesity. These are the traditional risk factors. However, these traditional risk factors explained heart attacks less than the non-traditional risk factors. So what are the non-traditional risk factors? And there's a long list of them. Metabolic syndrome, which you can consider obesity and diabetes, so I'm not sure why they didn't include that in that one. Kidney disease, inflammatory rheumatic disease, so things like rheumatoid arthritis, lupus, things like that. And then HIV or AIDS, hypercoagulable states, so clotting states, people who have higher clotting factors or things like that. Psychiatric disorders, major depression and anxiety disorder, non-tobacco drug use, so cocaine, stimulants, cannabis, opioid use, family history of ischemic heart disease, obstructive sleep apnea, hypothyroidism, and female-specific factors, eclampsia, preeclampsia, early menopause, gestational diabetes, preterm delivery, history of pregnancy-related complications, things like that. And so what I want to point out here is that, and this will become very clear later in this presentation, that a lot of these non-traditional risk factors that again associated more with higher risk of heart attack, which is just an association, but it's just interesting to look at, are things that are stressful to people. So we have chronic diseases. People living with chronic diseases are more stressed out. Like it's harder to live with their diseases. Hypercoagulable states, so increased clotting states, psychiatric disorders. People who have psychiatric disorders have more stress in their life. Their autonomic nervous system is more in balance. Obstructive sleep apnea. People who aren't sleeping well or getting deep sleep are very imbalanced in their nervous system. Hypothyroidism, very imbalanced in the nervous system. So lots of different things here are basically people living with chronic disease that's stressing them out. I just want to draw that to your attention now. So remember that as we go forward. The traditional risk factors of poor metabolic health, diabetes, cholesterol, things like that, did not associate as strongly with heart attack as the non-traditional risk factors, many of them that increase our stress in our lives and how imbalanced our nervous system is. So just remember that. So if it's not cholesterol, then what causes heart attacks? Well, the traditional theory is there's this cholesterol buildup in the arteries that over time creates this stenosis or narrowing of the artery, and that stenosis continually grows until it completely blocks the artery, or some plaque ruptures and causes a clotting issue, and it blocks the artery instantaneously. That's the general theory. Okay, so let's just explore that a little bit. So, does this gradual buildup of plaque actually restrict blood flow? So this is a few images of an angiogram. Someone was getting an angiogram, a heart cath procedure, and they were doing an angiogram. So they were injecting dye into one of the heart arteries. And you can see where they started to inject the dye here at the top. Right there, you can see the artery starting to form where they're injecting the dye. But you also see some dye here, but there's no clear connection between the artery, this dye, and here. So if there's no clear connection here, this dye is showing up here and it's also showing up here. How is it getting there if it's not going through the main artery? Okay, so here's more advanced of the imaging, right? So you can see more clearly the artery starting to form here, and it's also down here pretty clear, but here it's still really not clear, especially right here. Here you can see there's almost like this stenosis, almost complete blockage right there, but the blood still got from here to here. So here's just a more progressed through the procedure. You can see it more clearly up here. And again, you can see like barely any blood, almost no blood is getting through there, that severe stenosis. So it's coming here and it's still here, like it's showing the artery still showing up here. And that was happening way up here too. And here you can see it pretty full. Now it's completely perfused with the dye. And you can see that there's the dye here, and there's always like complete blockage here, yet blood still got over here, right? So how could that happen? Even when they just first started injecting it here, how did it end up over here? Even when there's just like this severe blockage, how did it get over there? The answer comes from the work of Giorgio Beraldi. Giorgio Beraldi was an MD, PhD, and he was a forensic pathologist. So he spent his entire career investigating pretty much cardiac death, sudden cardiac death. And he was looking at it from the perspective of a forensic pathologist. He wasn't trying to, you know, uh, I guess, confirm any certain theories that were out there, cholesterol blockages, whatever. He was just looking at things and learning how to study them and like, what happened here? How can I explain this sudden cardiac death? And so he investigated the heart vascular systems of various individuals after their deaths, and he probably autopsied thousands of hearts, maybe even tens of thousands throughout his career. But if you've ever been to like the Body World exhibits or the Animal Inside Out exhibits, they have these perfect casts of the arterial system of like an arm or a fish or something like that. And he actually invented the procedure to do that. So what he would do, he would inject the arteries with a plastic material, a latex or a neoprene. He waited for it to solidify and then dissolved the tissue around it with hydrochloric acid solution, and he was left with this perfect plastic cast of the arterial system. And because of the liquid nature of that, it would even get into very small little arteries and go into there, and so that he would have this really perfect cast, not just of the big arteries, but of the very small arteries that even an angiogram can't pick up. And what he found was, this is straight from his book, the one I have cited down there, in the presence of atherosclerotic stenosis, in the presence of a narrowing of an artery, with a lumen or diameter reduction greater than 70%, there was a dramatic increase in the diameter and length of collateral arteries. So anywhere there was a 70% narrowing of an artery, the body would build collateral arteries, so it would build extra arteries that go around that stenosis, so that blockage. And I've had many cardiologists tell me that some people have collaterals, some people are fortunate to have collaterals, and some people aren't. But angiograms can't really pick up these collaterals. They don't see them unless they're very big, unless they develop big collaterals. But most of them are very small. What Beraldi found with this technique over, again, thousands of autopsies was that any severely obstructed coronary artery lesion, even multiple ones, was always found associated with enlarged collaterals. Throughout his entire career, he never found one, a stenosis of an artery, that did not have collaterals that would divert the blood flow around. And so he found anywhere from 5 to 33 different collateral arteries could form around a stenosis. And it wasn't just like going from one side of the blockage to the other side of the blockage. It was sometimes it would come from this area of the heart over here. New blood vessels would form and flow over here, or flow from this side over here. And so there was collateral circulation always growing. Again, that's very different than what we hear from cardiology many times. And so here's an image from his book and some of his research articles. You can see here that the arteries are very small, right? There's a blockage here in this main artery right here, and there's so many collaterals going around it that are very, very small. So again, these won't show up on an angiogram because they're not big enough. You inject dye into there, the dye just doesn't show up as well on there. You just see the blockage, what we saw on that angiogram earlier. Now, I've also had people tell me, yes, but collaterals take a very, very long time to form. So you really have to wait a long time. It takes do the right things for a long time to get them to form. However, we have some animal studies, again, not human, but animal studies that show that these collaterals can form within 4 to 7 days. Which is very fast. So in the 4-day study, they gradually induced a stenosis or blockage in a rat, and the rat's body was able to build collaterals within 4 days that fully compensated the heart with blood, and no heart attack happened. So these collaterals can form very fast. Things that can make them form faster or make sure that they form more robustly is exercise, maintaining blood flow, and being insulin sensitive. Because if we're insulin resistant, these arteries can't form very well because insulin is this needed for the growth of these new arteries. If we're insulin resistant, that doesn't happen very well. Now, the fact that the body can build these collaterals, and it happens 100% of the time, according to Beraldi, anytime that it gets to 60, 70% narrowed or more, the body will build the collaterals. To me, that explains why, if you look at all the research on either elective stent placements and bypass procedures, that they don't prevent future heart attacks, right? So these are procedures like an elective stent. Like go in there, so they see blockages and everything, but the person's not having a heart attack, and they say we're going to place a stent here to try and prevent a heart attack. Or this is a really bad blockage. We need to do a whole bypass surgery. We need to open up the chest wall, do open heart surgery, and do a bypass surgery. And the research clearly shows, and it's not even like some says this, some says that. It's like the research pretty much all shows that elective stents and bypass procedures do not prevent future heart attacks. Whether or not someone has those procedures or not, they're just as likely to have a heart attack. Because to me, the body has already built a bypass. The collaterals are already there. Even if we can't see them because they're so small, they're already there. So doing another bypass or opening up that artery with a stent isn't really going to make a difference, right? It doesn't really address the actual cause of heart attacks, which we're going to talk about. And so that's just something that we need to note, right? Now, I'm not talking about a heart attack situation where someone's clearly having symptoms and placing a stent in that situation, because that can be life-saving. And that's what happened to me, right? They saved my life. Now, did they stop the cause of the heart attack? That's another question, which will become clear as we get to the end of this presentation. But here, I just want to show you there's lots of research to show that these procedures don't prevent future heart attacks. Now, this study here looked at 4,307 people who had a heart attack, and they found that 66.3% of them did not have plaque considered to be obstructive, and some of them had no plaque at all, right? So very similar to me. I had very little, if any, plaque at all, and I still had a heart attack. And in the study, they say that, okay, so without obstructed coronary arteries, then it must have been a plaque rupture, right? Some of these people had some plaque, and the plaque must have ruptured, caused an instantaneous clot to form, and that's what caused the heart attack. And so that's what their explanation is. However, there's evidence to show that that's not true. So there's a large percentage of heart attacks, I would say, that happen with no obstructed coronary arteries. So again, same kind of thing. There's these heart attacks called MINOCAs, myocardial infarction with non-obstructive coronary arteries, and that's said to be about 5 to 20% of cases. On an angiogram, will show no obstruction in the coronary artery anywhere, and which to them means that the arteries are less than halfway blocked. It's 50% or lower narrowing. So there's still some plaque, but or there could be no plaque and they could still have a heart attack and they're still having heart attack symptoms. And then there's also the NSTEMIs, which is less, they say like the more less severe type of heart attack. STEMIs, ST elevation myocardial infarction is much more severe, whereas a non-ST elevation myocardial infarction is tends to be less severe. However, they looked at 61,000, almost 61,000 patients with an NSTEMI enrolled in 25 studies, and 17,212 were found to have obstructive coronary arteries. Only 17,000. Of those 61,000, only 17,000 had obstructive coronary arteries that were 50% or more blocked, right? So doesn't quite add up. Like, why did these people have heart attacks? And they would say it's because of the plaque ruptures, and that's what causes it. However, Beraldi, this is another one of Beraldi's hearts that he studied. He found something very interesting. Lots of times he looked at people who had heart attacks. He looked at people who didn't have heart attacks. They died of something else. And he found people who died of like in a car accident or died by some other cause. And he found lots of them had 100% blockages somewhere in their arteries, right? And they never had no history of heart disease or history of heart disease symptoms or anything like that. Sometimes the people who did die of a heart attack and had heart tissue death, he would find a blockage here, like in this artery, but the tissue death that caused the heart attack was downstream from this artery, right? So, and there was no blockage here. So very interesting things. How could this happen, right? The blockages are what cause heart attacks, right? Well, that's what's thought. But he was finding something very different. So yeah, how do we explain this? So again, the idea is that these heart attacks that happen with non-obstructive coronary arteries must be plaque ruptures. There's plaque in there. It's not obstructive, but it's plaque, and it ruptures, right? So we get this plaque that's in there. This is stable, said to be more stable. This is more vulnerable, soft plaque, hard plaque sort of situation. This is what the industry says. And then soft plaques will rupture, right? They rupture and they cause this material flowing out, and that causes this clotting response, and that blocks the whole artery, and that's what causes a heart attack. However, there's a very interesting paper called The Myth of the Vulnerable Plaque, transitioning from a focus on individual lesions to atherosclerotic disease, burden for coronary artery disease risk assessment. And this study basically looked at all this evidence for the plaque rupture theory of heart attacks and found some very interesting things. I'll just read you some of the things they said. So we found that 75% of thin cap fibroatheromas. So thin cap fibroatheroma is just like when this plaque ruptures, this cap forms on it, it kind of heals over. Transition to thick cap fibroatheromas or fibrotic plaques within a 12-month interval, presumably secondary to rupture and healing. None of these patients experienced an event during this period, providing further evidence of frequent subclinical plaque alterations. So they're basically saying that plaque ruptures happen often, but they rarely cause a heart attack. These people had these plaque ruptures that form this thin cap fibroatheroma, and within 12 months they completely healed, but the person never experienced heart attack symptoms during this time. This one, of the many plaque ruptures occurring in patients with atherosclerotic disease, very few will trigger symptomatic events, rendering it exceedingly difficult to predict adverse outcomes associated with particular lesions. So basically, plaque ruptures happen all the time, and very few actually cause a heart attack. Conversely, meta-analyses have not demonstrated reduced rates of myocardial infarction or death with lesion-based treatments, which is stent placements and bypass procedures, right? So they're treating the lesion. They're either bypassing the lesion or they're going in and opening up the lesion with a stent. And they're acknowledging here that those procedures don't prevent future heart attacks. People have those, and it doesn't prevent heart attacks. They're just as likely to have one. Here they say, considering equal risk among the 3,160 plaques detected at baseline, the event rate associated with each plaque would only be 0.06% per year. So plaque ruptures happen all the time. They rarely cause heart attacks, but sometimes they do 0.06% of the time, according to this study, which is almost never, I would say. So it's possible, but it doesn't explain the amount of heart attacks we're seeing in society. So overall, strong evidence supports addressing the extent and activity of the atherosclerotic burden and thrombosis promoting risk factors for improved patient outcomes. But there is no conclusive evidence of incremental risk reduction with treating the lesions themselves, treating the actual stenosis, right? That doesn't prevent heart attacks. But I want to draw your attention to two things because we're going to talk about them later. And that is that the evidence supports addressing the extent and activity of atherosclerotic burden as a whole. How much plaque is there as a whole, which we're going to discuss why that is assessing of risk, and thrombosis promoting risk factors, clotting risk factors for clotting. Those are the two things that, based on the review of all this literature on plaque rupture theory and heart attack risk, those are the things these authors are saying we should pay attention to. The total atherosclerotic burden, how much plaque is actually there, and clotting risk factors. Okay. So what happens in heart attacks and strokes? I think we can all agree that it's clotting, right? It's a clot that forms, and we have to go in. After all, whenever you have a stroke or a heart attack, they don't go in there and administer cholesterol busting enzymes. They administer clot busting enzymes. That's what they do to dissolve the clots. So why does the body initiate clots? Well, if you cut your finger, right, then your body initiates clotting because it's bleeding, right? It has to stop the bleeding. Otherwise, you bleed out. So the scab that forms is the clotting material that forms to stop that bleeding. But what if we get damage, like similar to a cut on the lining of our arteries? What if our endothelial layer gets damaged from a whole variety of things? It could be endotoxic bacteria. It could be toxins in our blood supply, heavy metals, herbicides and pesticides, things like that. All these things, plastics, all these things have been shown to cause damage to the lining of the artery. Fluctuating blood sugars, moving up and down all day long, like an uncontrolled type 2 diabetic. All those things have been shown to cause damage to the lining of the artery. And when that damage happens, body tries to repair that damage, right? And that's through clotting material. Now, atherosclerosis is my explanation of that is a different lecture, but that's things that can help that would cause the body to initiate a clot, right? And so way back in 1856, Rudolf Virchow came up with this thing called Virchow's triad, originally in veins, but it was also shown to be true in arteries later, found that what causes clotting is endothelial damage to the lining of the artery, hypercoagulability, increased risk of clotting, right, blood clotting, and hemodynamic changes. So basically changes in blood flow dynamics. Those things right there, if you have damage to the lining of the artery, viscous blood, hypercoagulable blood, and changes in blood flow dynamics, those things increase the risk of a clot forming, right? Nothing there about cholesterol. So in order to understand why society is at such an increased risk for clotting, we have to understand what's called exclusion zone water. And I've talked about this in many posts online. I've talked about this at many talks, but exclusion zone water has been discussed by many different scientists over the years. So there's lots of people that deny this phenomenon happening out there, but the literature is very robust in this evidence for this exclusion zone water. Dr. Gerald Pollack has probably made it the most notable. He talks about it the most. He wrote the book, The Fourth Phase of Water. But many scientists over the last 100, 200 years have come across this idea that water exists in a different state than ice, liquid water, or steam. And so there are many books about it. Gilbert Ling, brilliant scientist, like Gilbert Ling's work is what allowed us to come up with the technology for an MRI. Albert Szent-Györgyi was the winner of a Nobel Prize for discovering vitamin C. Baewon Ho, very prominent scientist. And all these scientists, including James Clegg, Jim Oshman, Fritz Albert Popp, lots of different scientists have discussed structured water. And you can read their books right here, some of their books you can read and look at all the literature supporting this theory. So what is exclusion zone water? It turns out that water can hold energy. And when water holds energy and it gets next to a water-loving surface, this hydrophilic surface, it will rearrange its molecules in a certain way and become what's called structured water or exclusion zone water. And so what happens is one of the hydrogens is cleaved off of water, and the oxygen and hydrogen that are left team up with other oxygens and hydrogens, and they kind of link up and they form this lattice-like structure. And we get the kind of like fence panels that layer up on like that. This is the chemistry. And so this is technically not H2O anymore. It's H3O2. And it's the consistency of a more of a gel, right? So it's not ice and it's not water, but it's more like the consistency of raw egg white. It's kind of gelatinous nature to it, or Jello, or bone broth that has gelatin in it. You put it in the fridge, it becomes gelatinous, and it forms these layers and kind of builds itself up on these hydrophilic surfaces. And all biologic surfaces in the body are hydrophilic. So in Dr. Pollack's lab, he states that we also saw exclusion zones next to natural biological surfaces that included vascular endothelia. So on the lining of the artery, they get this layer of structured water that lines it like this, and the hydrogen ions that were cleaved off get concentrated in the middle, right? So what's the relevance of this layer of structured water being there? Well, here you can see it in one of Dr. Pollack's images from one of his studies. The vessel wall is here. There's this exclusion zone layer, and all the red blood cells and everything else in the blood is concentrated in between that, and it cannot touch the lining of the blood vessel wall. And there's plenty of evidence, not just Dr. Pollack's work, but if you just go into PubMed and type in cell-free layer, there's plenty of evidence that the arteries, the arterioles, the capillaries have this layer of cell-free, this cell-free layer there, where the red blood cells are the cells they're talking about, cannot get past that layer. There's this layer that excludes them from it, which is hence the word exclusion zone water. So also, if you look at this, it's one of the best depictions I've found of exclusion zone water, although it's not entirely accurate because they're depicting whatever these are. I guess they're saying LDLs in the exclusion zone water, but that's impossible. That can't really happen, which you'll learn here in a minute. But I just wanted to point out that the glycocalyx here, this is the endothelial cell, and there's this glycocalyx kind of brush border shag carpet stuff on the lining of the blood vessels, and it's said to be this anticoagulant gel layer. And the glycocalyx is not what makes the gel. The glycocalyx is providing hydrophilic surfaces, lots of surface area for water, which the blood is half water, to form structured water on the glycocalyx. So it makes it this anticoagulant gel layer. But it's very interesting that it's anticoagulant, right? Which shows the relevance to structured water as an anticoagulant. So the reason it's called exclusion zone water is because these kind of fence panel like things that are lined up, stacked up next to each other, they don't line up completely in line with each other like this. They kind of line up offset, which makes for a very small space here. And it makes it so that almost nothing can get through that. So Dr. Pollack notes in his book, even red blood cells, several strains of bacteria, and ordinary dirt particles scraped from outside our laboratory were excluded. The protein albumin was excluded. And so I noted that the protein albumin was excluded because that's the smallest protein in the blood. If that can't penetrate structured water, nothing bigger than can penetrate it either. And so if we look at certain sizes of things, albumin is about 3.8 nanometers in diameter, right? Red blood cells, much bigger than that. So that's the exclusion zone, the cell-free layer, right? They can't penetrate the structured water. They can't touch the lining of the artery. It turns out an LDL molecule of cholesterol, lipoprotein, is much bigger than that as well. So if we have structured water there, it can't touch the lining of the artery. Same with an HDL, which is the smallest lipoprotein we have, right? Even smaller than small, dense, oxidized LDLs, it still can't penetrate structured water. And so it can't touch the lining of the artery. It turns out that even sodium ion, which is 0.273 nanometers in diameter, can't penetrate structured water. But potassium ion can, 0.25. So the difference there is 0.02 nanometers between what can penetrate structured water and what can't, right? And I always point out that nitrate ion is smaller than potassium ion, so it's the precursor to nitric oxide. People always ask that because when the cells that line your artery produce nitric oxide, it can come out through the structured water into the lumen of the artery and dilate the blood vessel, that kind of stuff. And it's all based off this Hofmeister series of hydrated ions of minerals, right? So the cutoff between what can penetrate structured water and what can't is right here, sodium, potassium. So we have this layer of structured water surrounding the lining of the artery, and it's protecting the artery, right? Nothing can get to it. So again, one of Virchow's triads is we want to prevent damage to the lining of the artery, protect the endothelial layer. Structured water is how we do that to prevent clotting. Now, another phenomenon we see in structured water is that it's very electronegatively charged. So because of the way the hydrogen and oxygen team up, like water is a balanced molecule, but now it's missing a hydrogen. So it's more electronegatively charged because oxygen is a more negatively charged molecule. Plus, whenever they're linked up in this lattice-like structure, that means electrons can travel through these water molecules. And so that makes it also very negatively charged. So the electrons are negatively charged. So we have this very electronegatively charged area with this concentration of hydrogen ions next to it that have been cleaved off. And that creates a positive next to a negative. And that's a battery, right? We all know the batteries have a positive and negative end, right? And so what they've done in Dr. Pollock's lab is they've shown you can plug an electrode into the negative end, into the positive end, and you can power a light bulb. So this is holding energy. Basically, structured water is how the body takes in energy in the form of electrons and stores them. It stores them by building up structured water. And in this case, they've done experiments in Dr. Pollock's lab where they placed a tube in water, this tube made of a hydrophilic water-loving surface or material, and they shine infrared light on the vat of water, and water starts moving through the tube with no pump acting on it whatsoever. So in this case, the energy stored in structured water does the work of moving fluid through a tube. And Dr. Pollock notes that flow of this nature could persist indefinitely. Sustained water flow occurs inevitably in almost any scenario involving exclusion zones and radiant energy. So if we have water and we have a hydrophilic surface and we have radiant energy, infrared light coming from outside source, we will create sustained water flow. And they've actually done this experiment on chick embryos. This is the vascular system of a chick embryo after they've euthanized the chick embryo. So they've stopped the heart from contracting and the blood is still moving. And so this is 13 minutes after euthanization. You can see here when I click play that the blood is still moving and jumps around here for a minute, but then it settles down at the end. You can see it again. But I want to note that in the paper they wrote up on this, they noted that when they shine infrared light on the specimen, blood flow increased by 300%. So there you can see 16 minutes after euthanization, the blood is still moving on its own with no heart contracting. So blood can move on its own given these structured water mechanisms. So that's Virchow's triad number 2, is that we need proper flow dynamics, right? We need good, adequate blood flow to prevent blood from clotting. So why is this relevant? So technically, if we look at the amount of calcified plaque in the arteries, it associates with higher risk of heart attack. How can that be explained by clotting? It's because if we have lots of plaque in the arteries, right, that disrupts the blood flow. Okay. So remember in that study where they're looking at plaque ruptures, they said the extent of atherosclerotic burden is more important than, this plaque rupture theory. And so why is that? Because if we have tons of plaque in here like this, in our arteries, in the artery wall, like that, it disrupts blood flow. It creates narrow spaces for blood to flow through. It creates these weird ridges like this, like that. And when we do that, when we disrupt the blood flow, it creates turbulence, right? It creates stagnant blood. You ever seen like water flow past a rock in a river and it kind of circles and eddies on the other side, right? And when we're doing that, especially if we're dehydrated, we have lots of inflammation, we have very viscous, kind of thick blood, then we're more likely to get this clotting if we have this plaque in there that's creating these turbulent blood flow vortices happening. And we have pretty of evidence for that, you know, um, resonance time. So how much time blood spends in an area in a blood vessel dictates whether it'll clot or not, right? And we all know that people who have like arrhythmias, they're more at risk for clotting. Why? Because arrhythmias, when the heart's beating kind of aberrantly, it increases the risk that blood flow gets stagnant in some places or blood stays in some area, and that increases the risk for a clot, right? So we need to keep blood moving. And we know this, nature tells us this, right? It's the difference between a river that's flowing, right? It's always beautiful. Things are moving. It's pushing things out, all this kind of stuff. Whereas a puddle, it's stagnant, right? It gets dirty. It gets full of bacteria, may accumulate debris, that kind of stuff. We need things to be flowing. And so again, that's Virchow's triad number 2, is that we have to keep blood moving, keep blood flowing. Now, the last aspect of this is structured water doesn't just form on the lining of the arteries, it forms on any hydrophilic surface, right? So any water-loving surface, and anything in the blood, the lipoproteins, red blood cells, anything in there is a hydrophilic surface. It's a biologic material. And so structured water forms on the red blood cells, on the lipoproteins, things like that. And so it forms this negative charge around these molecules, around these substances in the blood, right? And they've measured this. They call it zeta potential. This is the zeta potential of a red blood cell or lipoprotein or anything like that. So we have this negative charge here. And the negative charge is attracted to the positive charge. Because remember, the formation of structured water happens here, and that cleaves off a hydrogen, and it leaves the rest of the blood very positively charged with these hydrogens. So the negative charge is attracted to the positive charge. But if it gets too close to another negative charge, they'll repel each other because like charges repel. Like two ends of a magnet don't stick, right? So if we have enough charge on our red blood cells, they won't clump together and stick together, right? And if they clump together and stick together, that's a hypercoagulable state. That's just asking for a clot to happen. So we need to build structured water on the elements of blood as well. And so here's the difference between our red blood cells floating through the blood all separate like this, or floating through all clumped up. This is called red blood cell aggregation or rouleau formation, when they kind of stack up like pancakes. So we want to prevent this type of situation. And the way we do that is based off of charge, the charge the body holds, building structured water. And erythrocyte sedimentation rate is a very commonly taken test. It basically it measures how quickly your red blood cells clump together. Once you take them out of the body, how quickly do they clump up together, right? The sedimentation rate of a red blood cell. And so if it clumps up together too fast, that's a bad sign, right? At that instance in time. And erythrocyte sedimentation rate has been shown to be a very good predictor of things like heart attacks, strokes, atherosclerosis, heart failure, all these different things. So we want the red blood cells to have nice charge, evenly spaced. They're kind of magnetically attracted to the space between them, but not to each other, so that everything's kind of hooked up like train cars moving together through the blood in a very thin, the blood thinning state from a biophysics perspective, rather than a blood thinning state from a biochemical, like a blood thinner or things like that. We want to create this separation of red blood cells. And ESR can give us some sense of that, but it's really just one snapshot in time. Like what that is, it's entirely different when you're in the lab getting your blood test taken versus when you're outside with your feet on the earth in infrared light and things like that. So yeah, so building exclusion zone water on the lining of the artery to protect the lining of the artery and keep blood flowing and moving, and around the red blood cells and elements of the blood to keep everything evenly spaced, prevents all aspects of Virchow's triad that causes clotting, right? So how do we build structured water? What's the best way to do it? Well, there's many things that have been shown to do it, but the number one thing that's been shown to do it that they found in Dr. Pollack's lab was that infrared light was the most effective at building structured water. All wavelengths of light from the sun, UV through infrared, will build structured water. Your body's soaking in that energy and using it to create structured water in the body. But infrared, this side of the spectrum, far infrared, was the best at it, right? So you can see here they have a hydrophilic surface with some exclusion zone water on it, and then they add infrared light to it, and the exclusion zone builds exponentially, and it excludes all those particles that they had dissolved in that water. It pushes them away because nothing can penetrate it, right? Why does that make sense, right? Why is like here's all this research I'm telling you about. Why does that make sense? Because life is supposed to be lived outside, right? And 50% of the sun's rays are infrared. There's no mistake in that. Anytime the sun is up, 40 to 50% of its rays are infrared. The other colors of light fluctuate throughout the day, but the infrared and red stays the same. And that's because it's supposed to be charging our bodies. All life on this planet lives outside of infrared light at all the time. So that's what causes clotting, right? So we could sit here and say, okay, maybe I was in the wrong environments, and this clot happened because of this coagulation. Regardless, talked about how it wasn't cholesterol, but we talked about how I could get into this situation where this 100% clot formed. I mean, they went in there, they found this 100% clot. Okay, that could be the explanation right there. We could stop right there. I was in a bad environment. However, if we look at my angiogram here, over here, you can see that there's a blockage right here, right? There's almost no blood flowing through here, yet there's blood here. Okay, so the blockage formed. Now you can see that the blood kind of gets faint here. It's not really flowing that well into the tissue of the heart here. And that's interesting, right? Because this heart tissue is technically starving for blood at this point. It's devoid of oxygen and nutrients, which is causing heart tissue death, which is why I'm having chest pain. However, what determines the flow of blood is the oxygen or the tissue demand for oxygen and nutrients. And this tissue down here is starving for oxygen and nutrients. So why is that blood sitting there? Why is it not flowing into this area here and providing it with the little bit that it does have, right? That doesn't make sense. right? And so let's explore that a little bit. Why could that be? There is such a thing called this no reflow phenomenon. This is very well noted in cardiology. I've had many cardiologists tell me this, that um, that the when they open, like they go in and they find a blockage and they place a stent in there and they open it up, right? And when they open it up, the blood still doesn't flow, right? It still doesn't go through here, right? Which suggests why this wasn't flowing here. So this is something we see in cardiology, and I want to try and explain that to you, what that is. So this is probably one of the most fascinating things I've ever found, and this was done by Beraldi, right? Giorgio Beraldi. So again, he was an MD PhD. He was doing a heart cath procedure on somebody. So he was doing an angiogram. He went in through the femoral artery. They go up and they're looking at the arteries that they're in there, looking at the arteries of the heart of this 45-year-old man. And I'm just gonna move myself over here so I can read this to you. So I'm going to kind of read the first part of this to you. So a 45-year-old man with unstable angina developed persistent ECG changes of myocardial ischemia during coronary angiography. So what happened, they were doing the heart cath procedure and the guy started having a heart attack, right? He started having these changes on the ECG. So he had an ST elevation and he was having chest pain all of a sudden, right? And they were in there looking at the arteries. He said occlusion of the left anterior descending branch was documented 20 minutes after these changes. So they were in there looking at the arteries, and when the guy started having symptoms, there was no blockage, right? There was some plaque in there. They could see the plaque, but there was no blockage. There was no occlusion anywhere. And he said then 20 minutes later, after these changes, after the guy started having symptoms, the blockage formed. And then they tried all these things. They tried nitrate. They tried a calcium agonist. They tried urokinase. They placed a stent trying to open up that blockage. And then eventually they did emergency bypass procedure or whatever. And none of those things caused the blood flow to restore again. Okay. So they were opening up the clot and bypassing and everything, and none of that caused the blood flow to happen again, which is very interesting. Okay. So just keep that in mind. Now they were able to, this guy unfortunately died 12 months later, and they were able to, Baraldi was able to autopsy him and look at his heart, and they confirmed that the guy did have tissue death. He had scar tissue there. So they confirmed he did have a heart attack, right? But the heart attack happened 20 minutes before the blockage occurred, or started 20 minutes before the blockage occurred. So I want you to keep that in mind. Very interesting case study that was published back in 1990 from Beraldi. So how could that have happened? How can we have a heart attack with no blockage whatsoever? Well, based on my research, I found that there are three imbalances in the body that can predispose us to this type of thing happening. One is you're going to have poor metabolic health, which means that your body is running on probably more glucose than it wants to, especially your heart. Um, we could have oxidative stress, high amounts of inflammation or oxidative stress, which means low nitric oxide. If you have high amounts of inflammation, your body is using nitric oxide as an antioxidant, resulting in low levels of nitric oxide. And then we can also get this imbalance in the stress response of the autonomic nervous system, which means we have poor coherence with our environment. We're stressed out pretty much. Our body, our nervous system is receiving too many things to tell us to be in a stress state all the time. And we'll talk about that a little bit more. So I want to put this together for you. How could this cause a heart attack, heart tissue death, right? So if we have this gradual inhibition of parasympathetic activity, we have this gradual stress response, right? So we're having like our bodies are, people hear about we're in the stress state or non-stress state, right? The stress state is the sympathetic activity and the non-stress is the parasympathetic, right? We're in one or the other, but we're never in one or the other. We're always getting signals from both and they're kind of balancing each other out. If we get a surge in a stress response, we'll get a lesser surge of a non-stress response and to kind of hold things back, right? But we get this gradual inhibition of the non-stress response. So then the stress response can happen and the non-stress response doesn't balance it out. And that can happen from life, right? Just all the things that are stressing us out in life, which we'll talk about later on. And we can get this depletion of nitric oxide due to high inflammation. That inflammation can come from stress itself. It can come from toxin exposures. It can come from a glucose-based metabolism and having poor metabolic health. There's lots of different reasons why we have this inflammation or oxidative stress that depletes nitric oxide in our bodies. And then we have this stressful event leading to a sudden increase in sympathetic activity. So with this inhibition of non-stress signaling and inflammation, we go through something stressful, right? And that stressful thing causes this surge of stress signal to the heart. Okay, so I just want to, it's not working. Here we go. So we get this gradual inhibition of parasympathetic activity. So this is just someone looking at heart rate variability prior to someone having a heart attack. They just happen to be measuring this person's heart rate variability, and you can see that, you know, in the hours before the event, it was declining, 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 and then the event happened, and then slowly it recovered after the event. Okay, so this depletion of nitric oxide. So basically, we can look at this idea that nitric oxide acts like an antioxidant. So if we have this high oxidative stress, we have this high inflammation, nitric oxide is being used to quench that inflammation instead of do its job. And that causes a decrease in nitric oxide. And then we get this surge in sympathetic event. So I want to give you an analogy here. So if we have this inhibition of the non-stress signaling, this is kind of like you're walking your dog, right? You're walking your dog and your dog sees your neighbor and says, "Oh, I'm going to attack that person," right? And so your dog has an attack response and it goes for your neighbor. That's the stress response. That's the stress response that's happening. Typically, what's supposed to happen is you're supposed to also have a non-stress response. You have a leash, right? And that leash keeps the dog in check. So even though the stress response is happening, the leash is the non-stress response or the parasympathetic activity keeping it in check. In this situation, the stress response happens and the leash is not there. Okay. And so that the dog can then go for the neighbor and something bad happens. So it's the same kind of thing with the heart attack. We get this increase in sympathetic activity, right? This surge of stress response, something stressful happens to us. And we get the failure of the non-stress response. And that can fail from a few different things. One, because we inhibit it because of our stressful lifestyles and we get it disinhibits it there or inhibits it. And also the other thing is that the non-stress response is, in order to get into heart cells, needs nitric oxide. So if we're living in this high inflamed state, then we have low nitric oxide, this signal can't get in. So we get this surge in sympathetic without the lesser surge to balance it out. And that sympathetic stress signal is allowed to go rampant, right? And so what happens when that happens is this surge of adrenaline causes heart cells to revert to burning glucose, where heart cells prefer fatty acids and ketones. It's well established in the research that they prefer fatty acids and ketones. We get this surge of increased stress, and that forces the heart cells to revert to burning glucose. Same kind of thing is that if I go for a run, that's a stress response to my muscles. What do my muscles start doing? They start burning glycogen stores in the muscle. And when you burn glycogen, what does that do? It causes, here's the study that shows that when we get this surge of adrenaline, it inhibits the shutdown, it suppresses the inhibition of glycolysis. So the use of glucose. The heart doesn't want to do that. So it's the surge in sympathetic causes the heart to start burning more glucose than it wants to. And when it does that, when you burn glucose, it builds up lactic acid, right? And hydrogen ions, which is why if you go for a run long enough, your muscles start to burn because there's lactic acid and hydrogen ion buildup in there because you're burning glucose. When that happens in your heart muscle, right? Because of this surge in sympathetic activity, you start burning more glucose. That causes lactic acid buildup. What is that? Chest pain. Now we're getting a muscle burn in our chest and our heart. And that's painful, right? This is what angina is on a low level. If it goes full blown, it can be a heart attack. So when that lactic acid builds up, that does two things. One, it prevents calcium from entering the cells. Here's just a study that shows that in this situation, the production of lactate is increased up to 8 times in that heart tissue. Okay. And that prevents lactic acid. That lactic acid prevents calcium from entering the cells. And if calcium can't enter a muscle cell, then they can't contract. Calcium is needed to bind on some of the myofilaments in muscle so that it can contract, right? If calcium can't enter the cell, we have an issue, right? So without calcium, muscle cells start to kind of like spasm. They start to do this like this. And we also get this buildup of lactic acid and hydrogen ions causing this paradoxical bulging, right? And so what happens is we get a swelling in the tissue because the lactic acid is building up. So now the swelling in the tissue is growing like this and it's pushing out. And when it's pushing out like that, the blood can't get in anymore because the pressure is greater coming out than this getting in, this blood getting in. And so if blood can't get in there, that's a problem, right? This causes localized edema, dysfunctional cell walls, and necrosis, which is tissue death, which is what we call a heart attack, right? So this all happened from a stress response, something stressful that happened. So if we're looking at my angiogram here, we have this blockage, right, that they found. We have this blood sitting here doing nothing, right, just not flowing into here. And we have these arteries, these smaller arteries down here that you can see are very low in blood flow. They're not as solid as, say, this one here, right? And so what could be happening is I had this stress response, which we'll talk about what happened to me just before the heart attack. And I had the stress response cause that whole chain of events I just told you about, and it increased the pressure here. And the pressure now pushing the blood away from the tissue, causing tissue death, which is down here where I had the tissue death, pushing the blood back up this way, right? And I don't know if that blockage was there or not. Maybe the block was there and I had collaterals built around it. But with a CAC score of 0, it's hard for me to believe that I had 100% blockage here and none of it was calcified. So to me, what happened, I think, is that this stress response thing happened, caused the tissue death here, pushed the blood back up and pushed it so it couldn't get back down here, and then the blockage formed later. Because when it's pushing blood back up this way, what does stagnant blood do? It clots, especially in a most turbulent area of the heart, which is the left anterior descending artery, most turbulent blood flow, the area under the most pressure, it clots right there. And once the clot forms, then obviously there's two problems we need to fix. We need to fix this autonomic nervous system signaling causing this to happen, and now we got to fix this too, right? Which is why people always say, well, yeah, but they placed the stent and then my symptoms went away. Yeah, they placed the stent and they gave me morphine right about the same time. So the morphine calmed my stress response, and then they had to go fix this as well because this was a new development. They blame the whole event on this blockage. But in reality, this happened after this, potentially, right? I'll never be able to know for sure, but based on that case study, this is a possibility, right? Now, it's interesting that study I showed you about the no reflow phenomenon, which they see in cardiology all the time, where they go in and they place a stent in someone having a heart attack and flow does not reestablish. Why could that be? Because they place a stent and this process is there's still more pressure here. So even if they open this up, it's still not going to flow because the pressure is coming out here. And if you look at what this study says, microscopic examinations showed that the cardiac cells within the non-reflow area were swollen, right? So this edema happened. And that edema happened because of this imbalanced nervous system stress signal to the heart. Cellular edema compromising the capillaries was confirmed in more than one experiment. So the swelling that happens here is preventing the blood from getting down there. And that potentially could have happened because having nothing to do with this blockage here. It happened from a entirely different mechanism through the nervous system. Okay. And the thing about this is that we subconsciously know this already, right? Because the real question here is what percentage of heart attacks that are blamed on blockages were actually an entirely different mechanism. And medicine goes in and they find the blockage and they open it, and sometimes it reflows, sometimes it doesn't. Like sometimes the pressure is greater going this way, so it reflows. Sometimes that pressure is not greater, it's not healed yet or whatever, the swelling hasn't gone down, so they open it up and it doesn't reflow. But we already know this. I mean, just think about it. Like when people say it all the time as an expression is like someone jumps out from behind a door and scares them and they say, "Oh my gosh, you're going to give me a heart attack." Like we know that being stressed and having that moment of sympathetic surge, subconsciously, we know that causes heart attacks or it contributes. That's why we say things like that. We also know that the heart is this organ that we tend to assign so much emotion to, right? Or we attribute so much emotion to. I love you with all my heart, not I love you with all my spleen, right? It's always heart, or we gave it our heart. Or when someone breaks your heart, you're like, my heart hurts, right? We break a heart. So there's this emotional aspect to this organ. We feel our emotions with this, and that's a whole nother lecture altogether, which I've given at different conferences. But we know there's an emotional connection to it. And then we look at all these studies here that I post. Cardiac events, heart attacks are more common on Mondays, right? When people are going back to work to potentially jobs they don't like, or they're just dreading the work week or whatever. How about daylight saving times? There's definitely increased risk of heart attack on daylight saving times. When we shift the clock an hour, um, then that disrupts our circadian rhythm. And for people who are already stressed out, that's just the straw that broke the camel's back for them, and it causes a heart attack. How about there's tons of studies that show that holidays, national holidays, more traditional holidays, Christmas, New Year's, things like that, even sporting events where people are very passionate about their teams or are betting on sports and losing lots of money potentially. All those things have been shown to be triggers of acute myocardial infarction. Here you see sporting events affect spectators' cardiovascular mortality. It's not just a game. And then here was a study where they looked at increase in cardiovascular death, heart attacks from psychological stress after a fatal earthquake in Athens in 1981. So all this stuff, very relevant. Like we know this, it's all in the literature. It's just that medicine is so hung up on this cholesterol theory and this blockage theory that the blockages are causing the heart attacks. And so their entire system is set up to address those things when there's this elephant in the room of, hey, this is imbalanced nervous system signaling to the heart causing these events. And there's tons of research for it. But that's just not profitable to do. The procedures and the medications are more profitable. However, despite those procedures and medications, heart attacks and cardiovascular disease in general is the #1 cause of death worldwide to this day. So those things aren't working because we're not addressing this. So yeah. So how do we address this, right? So what's imbalancing our nervous system? What's causing this imbalanced nervous system signal to the heart? Um, Unfortunately, our upbringing is one of the key players here. Our nervous system, like the work of Dr. Stephen Porges, has shown that our nervous systems, when we're born, is not fully developed. And that first year to 2 years of life is incredibly important for the proper development of a nervous system. So if we grow up with childhood trauma or neglect or anything like this, it can totally kind of make the baseline for our balanced nervous system can be off, right? So those people who go through those things are kind of struggling against that most of their life, and it makes it more likely that these things are going to happen. But when we look at the environmental signals that are imbalancing our nervous system, it's many different things. It comes from external environment and what's surrounding us externally, and our internal environment, because our heart and the electromagnetic field of our heart is measuring everything. It's measuring our external environment. So that means these non-native wireless signals and electromagnetic fields that have not been around except for the last 150 years. Our relationships, are we in toxic relationships? Do we have toxic relationships in our lives? Do we have loving, rewarding relationships and that types of things? Artificial light disrupting our circadian rhythm. Disrupted circadian rhythm and your biological clock is incredibly stressful to the nervous system, and how well we're connected to the biofield and to the ether. There's lots of research on how the heart is our connection to our biofield and or the biofield of the earth and the ether that connects all of us, this collective consciousness. And then also internally, how well our body is synced up and communicating with itself. So that means cell to cell communication, whether that's through fascia or mitochondria emit electromagnetic fields that communicate with each other, or our nervous system itself, or just more quantum aspects of things like light and sound that's happening in the body. We're all giving off infrared light. So all these things are communication things. Also, your biomechanics and your posture. How is your nervous system holding you? Right? Is it holding you in a state that's kind of like shameful, like this, like a dog tucked between, with tail tucked between its legs? Like, are we holding that posture? Or are we holding this proud, confident posture? Right? And that's not necessarily just like, do I hold myself that way? Do I force my muscles to do it? But it's really, how is our nervous system choosing to hold us? All that stuff is being picked up internally and also measured by the heart. And the heart is sending that information neurologically and electromagnetically to the brain. And the brain is sending that signal back down to the heart, right? And to the rest of the body, really, but to the heart. And whatever the brain is sending down is dictating how balanced the signal of the nervous system is to our heart. And so if we want to change the way that system is being signaled to the heart, we change the environment around us, right? We have to change our environments. So what should we do, right? How can we change that environment? How do we build exclusion zone water to prevent the potential clotting type of heart attack, which I do think is one reason we could have a heart attack, even without the nervous system imbalance? And how do we balance the autonomic nervous system? And fortunately, the things that help us do those things are mostly the same things, right? And it all makes sense when we look at it. So basically, we need good water, right? We need to drink good water that is full of minerals, free of toxins, and has been energized in some way. It's been moved around, it's been put in the sun. We need this water. Why does that make sense? Because that's what nature does to water. Water in nature is always in contact with the earth. It's under sunlight and it's moving, right? It's moving through rivers and streams. It's crashing on the ocean, on the beach. It's tidal currents, it's evaporation, precipitation. Nature is moving water. So we need to move water. And so then we need to avoid toxins. We need to avoid things that stress our nervous system, but also destroy structured water, like glyphosate, plastics, heavy metals. There's definitely evidence that glyphosate destroys structured water in the body. We need to avoid non-native EMFs, these wireless signals, which are forms of light, electromagnetic fields from electricity, but also radio frequency from cell phone towers and cell phones and airport radar and things like that. Non-native EMFs have been shown to reduce exclusions in water. They've also been shown to be very imbalancing to our nervous system signaling. We need to optimize our circadian rhythm. We need to sync our body to the day-night cycle of the sun. Because when we introduced artificial light, especially fluorescent bulbs and LED bulbs, it totally disrupted our circadian rhythm and our syncing up with the light cycle of the sun. Because the only lights humans had for so long was the sun coming up and coming down, right? And then we had fire, but that's not bright enough of a signal. There's not enough blue in that to disrupt circadian rhythm. So be very conscious of your circadian rhythm. We need to eat good fats because good fats are what allow us to take in the energy to build structured water to our body. But they've also been shown to a fat-based metabolism is balancing to the nervous system. We need to do more grounding and earthing, being in direct contact with the earth. It's like one of the biggest things for earthing is that it improves heart rate variability, which means it's balancing the autonomic nervous system. And we need to also grounding increases zeta potential around red blood cells and increases blood flow because it's building structured water when you absorb those electrons from the earth. We need to get more infrared light exposure. Infrared saunas, seeing sunrise and sunset has been associated with balance in the nervous system. Infrared saunas balance our heart rate variability, but it's also giving us infrared light to build structured water and prevent clotting. We need to exercise. Exercise, again, been shown to balance the nervous system, but also it when we exercise and create heat, that's your body producing infrared light, which is building structured water in your body. Cold exposure does a similar thing. Appropriately done cold exposure, not overdoing it and gradually increasing it, can help balance your nervous system, make your nervous system stronger and more resilient. But it also increases the heat production in the mitochondria, which is infrared light, and building structured water. We need to have positive, loving relationships and express gratitude. And if there are toxic relationships that we just can't remove ourselves from, we need to create boundaries around that toxic relationship, and make sure that we're not letting it affect us negatively. We have clear boundaries for this people or this person, and so that we can move forward and not have it negatively affect us. And then express gratitude. An attitude of gratitude has been very balancing to the nervous system, extremely balancing. There's tons of studies on that. And then we need to resolve stored or unresolved past trauma. Again, this could happen in childhood, and we need to move that through us. We need to treat the body to resort or remove the trauma from the stored place in the body, or gain perspective on these things that may have happened to us in the past, and gain a new attitude about them. But resolving and restoring that can be incredibly balancing to the nervous system and what the nervous system is feeling. So basically, what has happened, why we have this increase in heart attacks, is because we're spending too much time in environments like this office where we're under artificial light. We have worked these rigid hours, 9 to 5. We're not grounded. We're surrounded by EMF. All this stuff. Lots of times we live in toxic work environments where there's lots of competition for bonuses and all this stuff. And it's kind of this, instead of an environment of working together and uniting with other people, and working to achieve a common goal. There's a reason that religions have stood the test of time because people are working together to achieve a common goal, and they're creating community and all these things. And this work environment for many people, not everybody, but many people has created this competition, and removing ourselves from these things. We're also spending our time at home, either indoors, in front of this artificial light, not moving. We're eating processed foods, all these types of things. We're spending too much time in this environment and not enough time in these environments out here we're exposed to the things in nature where humans came from, that give us health, that balance our nervous system. We go for walks with other humans, right? Go talk to people. We are more connected than ever before because of technology, but we're also more socially isolated than ever before because of that technology. And these things are all creating imbalances in our nervous system that eventually one day could create these imbalances where if we have this surge of stress response, we're vulnerable to heart attacks. And that's how I make sense of it. So this survey here found that 93%, the average person spends 93% of their time either indoors or in an enclosed vehicle. So completely void of these environments where there's no nature around us. With nature, there's much less EMF. There's sunlight. There's balancing your circadian rhythm. There's contact with the earth. If you go do it with a community, like we need those environments more than these other environments. And unfortunately, society has made it very hard for us to do that type of thing and live in that sort of environment. To me, that is why heart attacks, whether they're clots or whether they're this imbalanced nervous system sending to the heart, that's that's um, that's the environment we need to be in. So, what caused my heart attack? To be honest with you, I don't know exactly. It could have been an acute clot, that blockage that formed there, or it could have been this imbalanced nervous system signaling to the heart that caused the clot to form later after the symptoms started. I'll let you decide, but I'll just tell you these few things. Was it clotting? I was dealing with some dehydration at the time. I was dealing with constipation, and I convinced myself that I only needed to drink water when I was thirsty. So I was having like maybe a cup or two of bone broth a day, and that was dumb. And I was getting ready to do something about it because of the constipation, but I hadn't yet. So dehydration can create viscous blood, which predisposes to clotting. I was also oxalate dumping at the time. So I had been on a carnivore diet for a while. And I've done urinalysis my entire life as a type 1 diabetic. And I looked back at my test the 9 months before the heart attack, and I had oxalates in my urine for the first time ever. And it's about 2 years on carnivore diet when people start to see oxalate dumping, which can be a very inflammatory situation, damage the lining of the artery, increased risk of clotting, imbalance in the nervous system. It can do a lot of things. But there was definitely oxalates in my urine at that time. Whether that played a role or not, I don't know. But also stress. Stress has been shown to increase 9 of the 14 different clotting factors in the blood. And so I was under a lot of stress at the time. So that can increase clotting as well. So it could have been the clotting type situation. However, there's also lots of things that could have made it the imbalanced nervous system situation. So at that time, I'd been type 1 diabetic for 25 years. And like I said, during high school and college, those were not well-controlled years. And so there's research that shows that being type 1 diabetic with even well-controlled, but not perfectly controlled, like never going to be like non-type 1 diabetic type numbers, leads to a gradual imbalance in the nervous system because blood sugar is being higher and fluctuating a bit more. That's stressful to the nervous system, and eventually it leads to this imbalance. But it was also during COVID, and there was lots of things happening during COVID, as there was for all of us, no matter what side of things you're on. COVID was stressful for all of us, whether you had to change how you worked, whether you lost jobs, whatever it was, whether you didn't agree with what was going on, it was stressful for all of us. And so that was the first time in my life that I kind of got caught up in politics and the news and that kind of thing because it had to do with health. I was also dealing with some relationship stress at the time. I was unhappy in a relationship, and yeah, so that was very stressful. And then a day and a half before I had the heart attack, I got some very stressful news about a close family member of mine. And it wasn't just the news, it was the inability of me or my family to get to this person to help them. We were just kind of sitting around waiting, hoping it was going to be okay. It was during COVID. They were in another country, and my family or I couldn't get to this person. So I didn't sleep well that night after I got that news. I spent all day that Monday trying to figure out how to get to this person. Didn't sleep well again on the next night, Monday night. And I woke up on that Tuesday morning that I had the heart attack, and just trying to distract myself, I did a pretty extreme workout where I would sprint up a hill, drop and do push-ups to failure, do walking lunges to failure. And I did like 5 sets of that. And after that, I came back inside. I was starting to make my first meal of the day, and I had a heart attack. I started getting the chest pain right here. So again, that was the situation. I'm not going to say one way or the other what caused it. You can decide for yourself based off everything I looked at or told you about in this presentation. But that's was my situation. So yeah. Now, what happened to me after the heart attack? So my diet stayed the same. It stayed very low carb, animal-based diet, animal foods-based diet, um, and uh, and then my exercise stayed about the same. Once I figured out that I could ride a bike rather than having to walk or run or anything to stay active, I started doing that. So my exercise stayed about the same, and my stress probably stayed about the same. Maybe even got a little bit worse after the heart attack because of some other things. But yeah, and then I did take a blood thinner for 6 months. So because of the stent that was placed in there, I took the blood thinner for 6 months because I didn't want any excessive clotting to happen because of that foreign object in there. And I want to point out that my lipids, these are the 4 tests that I got during the time, this year and a half, 2 years, that I'm going to tell you about after the heart attack. These are the lipids that I got. And so I translated them to European numbers there on the right. But yeah, they were elevated according to medical authorities. These were highly elevated, especially that last one. My total cholesterol was 515 and LDL was 452. So very elevated. And despite that elevation, despite having this heart attack, what I did do is I got an infrared sauna. I bought an infrared sauna. I used that 4 to 6 times a week for about 20 minutes at a time. I prioritized getting sunlight and putting my feet on the earth. I tried to do that as much as I could. I took a few supplements. I took taurine. I took, which is an amino acid. And then I took serrapeptase, which is an enzyme that can help break down clotting material. I took magnesium because it had blood thinning effects. And I took strophanthus, which is um, a balance, something that balances the stress signal to the nervous system of the heart. Um, I don't know that I would have taken all of those in hindsight, but that's what I did. And 3 months, 3 months after the heart attack, I went and got my follow-up echocardiogram, and my ejection fraction had returned to normal, 50 to 55%. And the tissue that was severely damaged and not conducting the signal was only mildly hypokinetic at this point, whereas before it was severely akinetic. It wasn't conducting at all. So it did recover. That may have happened on its own. And that, I mean, tissue improves, the body tries to heal on its own regardless. Did the things I do, the things I did try and or make that better? I don't know. I can't tell you, but I know that I got this result. At that time, the doctor did say that, oh, good, looks like you're decided to take your medications. And I said, no, I actually only took the blood thinner for 6 months, and he didn't really know what to say to that. Um, Now, the other thing that after I got that echocardiogram is when I really started doing circadian rhythm practices. And so circadian rhythm, optimizing sleep, there's a whole lot of information there about how that increasing melatonin and setting your body to the day-night cycle is incredibly beneficial for the vascular system. But this was the artery in my leg when I got that 70 to 99% blockage diagnosis. You can see the blood flow barely getting through there. But then a year later, I got a follow-up test, and it showed that it was only 0 to 49% blocked. And so it improved. And they actually sent the technician back in to do it again because the doctors didn't believe that it improved, but she got the same result. And at that time, the doctor said, well, we can't say it's better because we don't see these things get better. And I was like, well, I mean, it just improved. It saw it right there. Why aren't you asking me, how? Like, because even if I don't know, like, let's figure it out so you can help other people do this. But there was no curiosity there. And then a year after that, I got another test again, and it was essentially normal. That blood flow was through there. It only said slightly elevated velocities are noted at the distal superficial femoral level. So the artery was pretty much normal. I reversed the plaque in my leg there. And then I got another follow-up after that a year later, and it didn't even say slightly elevated. It just said completely normal. So yeah, it has stayed that way since then. And I could also run now. I could run, I could play soccer, do things without pain in my legs. So that was the real evidence, right? Because these tests are what they are, but the real evidence is that I felt the change. Like I can actually do these things again. And I have testing that shows potentially why. And then a little over a year ago, I got imaging of my coronary arteries. I just said, what the heck, let's go look at them and see. And they all came back clean. So you can see here that in the right coronary artery, there's a mild amount of plaque, which is what they found at the time of the heart attack. They said mild amount of plaque, but everything else was normal. So the LAD, lateral, the left circumflex, all no plaque in them whatsoever. And this is with LDL levels significantly higher over the last 4.5 years. No plaque whatsoever. So what's the take home? The main take home that I want you to have from this is that this is a bold statement, and I don't know that it's true, but I think artery plaque and myocardial infarction, heart attack, are two different things. I think medicine is trying to make them the same thing, and they may affect each other, right? They like if you have a heart attack, it could be worsened by having plaque there. But I don't think that plaques cause heart attacks, so it's very rare that a plaque specifically causes a heart attack. Um, and I think that medicine's trying to link them together. They're trying to make them the same thing and make them relevant to each other. One causes the other. And I think that's why they're being so unsuccessful with preventing them. Because they're great when they happen. Whatever they do there, whether it's the placing of the stent or giving people morphine or whatever, like those things seem to happen. They seem to save a lot of people, but some people it doesn't save. And I think that a deeper understanding of this type of thing is needed, right? And so I think that we need to start asking questions. No question should be off the table because clearly they don't have it figured out. And I think one question we should really ask is tracking down the plaque and treating the plaque, trying to prevent heart attacks, is that working? And I'd say the answer is no. So we need to do something different. We need different explanations. Whether or not what I said is true or not, I don't know. If it resonates with you, it resonates with you. But that's the way I understand things. And again, no question should be off the table. Until we can start eliminating this thing that's plaguing society, no question should be off the table. So that's my explanation of why I had a heart attack. Hope you enjoyed it. I know it was long, but hopefully you found value in it. And if you want to look more into my work or more information from me, I have a book out there about the heart, understanding the heart. You can also go to resourceyourhealth.com. I work with people in a 12-week online heart health mentorship program. So if you're interested in that, there'll be a link in the comment, or not in the comments, but in the description of this video that you can click to learn more about that and book a call with me, and we can explore that option. But you can also follow me on social media or here on YouTube. And hope you have a great day, and thank you for listening.